This webinar series is endorsed by the International Federation of Fertility Societies. So please take a look on this International Federation. And also, I would like to tell you that to the US attendees, you can submit the certificate to ABB and validate this certificate as credits for continuing education. So it's our pleasure to tell you that you can submit this certificate that you receive tomorrow on your emails to ABB. Now, to start with you and with 700 people together here, I would like Dr. Carlos Simon. Welcome, Dr. Carlos.
Thank you, Juliana. Thank you, Dr. Forman. Good morning from Boston, and good day to all of you in the different geographical locations that you are. Today, we continue with the scientific program of this webinar series on COVID-19 in reproductive medicine. And after the previous talks, lectures that you have in the link, we are going to go to the specific. And today it's a pleasure to introduce to all of you Dr. Eric Forman that will address what is the impact, or what could be the impact of COVID-19 in the IVF laboratory. The next presentation next week will be about the endometrium, about the mother, and then by Inmaculada Moreno. And then the next one will be just on the impact in terms of miscarriage, because the two main questions are whether there's some fetal risk. So Dr. Ruth Lacy from Stanford will address that. Dr. Roberto Romero, will address all the issues about obstetrics and also considering vertical transmission. And finally, we will have a review on what is in the child after that and what could be the impact of COVID-19. But going back today, again, I would like to thank you, Dr. Eric Forman, for his availability and the work and time that he has introduced in the preparation of today's webinar. As you all know, Dr. Eric Forman is the Medical and Laboratory Director of Columbia University Fertility Center in New York. He's a very productive clinical researcher that you all know, and he has lived the whole experience of this pandemic in the outbreak in USA, which is New York. So I think that we are going to learn a big deal from his presentation. And again, I want to thank him and give the floor for him. So Dr. Forman, the floor is yours. Thank you.
Thank you, Dr. Simone and Dr. Kuzi, for that nice introduction. I'm here in New York City, as Dr. Simone mentioned. I want to thank the Igenomix Foundation and the IFFS for endorsing this series. I think it's very exciting and timely to be considering the effect of this COVID-19 pandemic on all aspects of reproduction. My focus today will specifically be COVID-19 and IVF, but if you've been tuning into the prior week's webinars, there was the Chinese experience, the Italian experience. I feel also obligated to include a subtitle, the New York City experience, because this has really now become the epicenter of the COVID-19 outbreak really worldwide. Here pictured, for those of you who have visited New York, you know that Times Square is usually jam-packed with people, and it's not even this empty usually at 4 o'clock in the morning, let alone in the middle of the day. So it's kind of surreal being in New York right now, and even it's very quiet outside of my window here. So so I want to accomplish a few things during this talk. First, I want to disclose that I'm not an infectious disease expert. I'm not a virologist or an epidemiologist. I'm going to focus on the area that I know best, which I think is clinical and laboratory assisted reproductive technologies. I'm also going to mention some different products during this talk, and this is a very rapidly evolving field of how to do reproductive medicine during pandemic, and I have no relationships financially with any of these products, and I apologize if anyone was left out. Again, this field is changing very rapidly. So first, I want to give an overview, for those of us in the U.S. and those around the world who may not be following, what's the situation for assisted reproductive technology, IVF, in the U.S. I'll talk about what the official American Society for Reproductive Medicine stance and guidance has been, then what the response from various groups, including epidemiologists, fertility providers, as well as patients. I then want to talk about how this pandemic has changed how we go about doing the infertility evaluation, and how treatment, I think, will be changed for those who have continued and for those who start resuming care. Finally, I want to talk about a path toward resuming or continuing safe fertility treatment during this pandemic, and touch on the role of testing and what the potential impact for our staff and laboratories. How can we make the clinic as COVID-free as possible? Dr. Kuzi had a great presentation on the importance of testing and aiming for COVID-free clinics, at least in places with high prevalence like New York City. That might not be possible, but we can try our best and try to keep it as safe as possible. March 17th is actually normally a very festive day in New York City with a large St. Patrick's Day celebration and parade. At that time, in March 17th, 2020, the COVID-19 pandemic was already brewing and things were being canceled. The parade was canceled. The city was already on edge. But that day may really go down as a day that will live in infamy for reproductive medicine, as we all received news of the ASRM task force, which had the very difficult job of making recommendations based on this situation. And so the recommendation came down to stop all new treatment cycles and consider cycles that were in progress. And I personally, here in a busy practice, was in the middle of performing egg retrievals and had 5 or 6 frozen embryo transfers lined up that afternoon. And we received, this message through email and then text, talking to different doctors around the country. How are we going to interpret and implement this guidance? So I want to review what the guidance was. It was not a official guideline that usually goes through a longer review process with input from the members. This was a task force with rapid recommendations, which is understandable given the urgency. And so the components, this is all available on their website, were to suspend the initiation of any new treatment cycles, including ovulation induction, IUI, IVF, retrievals, FETs, anything not deemed as urgent cryopreservation. So someone diagnosed with cancer might be facing therapy that could damage their fertility, men or women, they could be offered, should be offered, if safe and possible, sperm cryopreservation or even oocyte cryopreservation, but not to initiate any other new cycle. And then it was recommended that we strongly consider canceling any other embryo transfers, including those, that I maybe had that day. Although those embryos had already been thawed, all of those patients chose to move forward. They then recommended that for patients who are in cycle, again, or require urgent stimulation, we could, consider continuing. They recommended suspending any elective surgeries, such as hysteroscopies and non-urgent diagnostic procedures, such as hysterosalpingograms and other, imaging modalities. And then there was a recommendation to minimize in-person interactions as much as possible and to use telehealth as much as possible. So this was a sort of temporary guidance with a promise to come back and review it no later than March 30th, and the hope of resuming usual patient care. And these guidance recommendations were updated on the 30th and again on the 13th, and basically reaffirmed, the findings. So this is currently still the position that we're in, and we're waiting for the next set of guidance in late April. There's also a new task force working on strategies to prioritize resuming care and how to do it safely. So we look forward to those recommendations. So, it's important to understand, the task force was balancing multiple factors, including the urgency of fertility treatment, and they were careful not to call it elective, but also looking at the health and safety of our patients, our providers, doctors, nurses, phlebotomists, embryologists, andrologists. But also they took a broader view, looking at our social responsibility as part of a organization and community to comply with national and local public health recommendations, and basically to really do our part in helping to blunt the impact, or quote unquote flatten the curve. So this was kind of the background for why these recommendations were made. In response, there was a lot of controversy, and some in our field felt that, and feel strongly that fertility treatment is urgent, not elective, and could be continued safely. And so there was actually a rapidly formed new group called the Fertility Providers Alliance, which met and came up with some recommendations and sent a letter to the leadership and the task force that's working on COVID-19 recommendations for ASRM. And this group, this letter was signed on behalf of over 400 fertility specialists from some of the largest practices in the country, accounting for a large proportion of IVF cycles in the US. And some of their feedback and their comments were that there was not much input from providers in developing these guidelines. As I mentioned, unlike other guidelines where it's circulated and comments are taken, this was very rapid and, again, an urgent situation, and so there wasn't much input. They also comment that most fertility centers are freestanding, separate from the hospital, so they did not feel like continuing fertility treatment care would detract from hospitals' ability to take care of sick COVID patients. And they also described a variety of different measures, which I will discuss later, to reduce disease transmission for those, seeking fertility care, and that this would not be business as usual, but this would be modified treatment during a pandemic. And again, they stress that infertility is a disease as recognized by the World Health Organization. We have an obligation to treat this disease and not delay. And so as we're doing a webinar now, over those first couple of weeks after the pandemic, there were webinars, in abundance. It was hard to keep up with so many. This is some pictures from a webinar that was shown on March 27th that actually included some of the members of the ASRM task force here, Kevin Duty, who has a private practice in Dallas, Marcel Cedars from UCSF, Jamie Griffo from NYU here in New York City, who's a key member of the Fertility Provider Alliance, and also Dr. Beverly Reed from Texas, who actually launched a petition in opposition of the ASRM guidance. During that webinar, where there was also hundreds of attendees, there was an informal survey for those in the audience, and you could see that the vast majority of those responding, nearly 90%, said they were following the ASRM guidance. So it seems like, although there was controversy, most practices in the US decided to take a pause and not initiate new cycles. In terms of the concept of flattening the curve and the epidemiological impact of fertility care during this pandemic, a group of 35 reproductive epidemiologists who study reproductive medicine, it came out very strongly in a article that's available on the Fertility and Sterility Dialogue page, saying that they contend that no REI provider should continue care that is not in complete compliance with the ASRM task force guidance to stop all new treatment and continue limited care only for completing in-cycle patients or providing urgent stimulation and cryopreservation for rare cases. In short, ASRM's quick and aggressive guidance should be applauded for its wisdom to mitigate loss of life across the country. Again, this was a very strong stance, and I think it's controversial, given how small of a population that the infertility patients represent in this country. Patients had a very different view, and that petition that I mentioned was put out online on change.org, and to date, as of yesterday, I believe more than 20,000 mostly patients have signed this petition basically protesting the task force recommendations to suspend treatment. And some of the text that's in that petition, again, reiterate that they were stunned that the guidelines called for essentially the shutdown of all fertility treatment, that treatment is necessary and time sensitive, that different parts of the country are seeing different rates of infection over different timelines, and basically they felt that it violated certain principles of patient autonomy and justice. And so that was the patient response. In terms of what patients are seeing out there, I think they're getting very confusing and mixed messages. While ASRM task force is recommending a pause on any fertility treatments that could result in pregnancy. So, they allowed for completion of IVF freeze-all cycles and urgent gamete cryopreservation, but no cycles that could result in pregnancy. At the same time, no major organizations, including WHO, CDC, ACOG, none of them have recommended that couples or women not attempt pregnancy naturally. And in fact, our patients are seeing messages quite the opposite. And this is an article from a newspaper here in New York, where early on in the pandemic, Dr. Oz, the same day that fertility treatment essentially shut down, was telling couples they should be trying while they're in quarantine. And then there's posts like this that go viral on social media, showing that there's going to be a baby boom. Basically, hand sanitizing products are sold out, but no one is buying the condom. So again, I think patients who are feeling like their precious time is passing, it's even more stressful to see messages about a baby boom. In fact, the science suggests that a baby boom is unlikely, actually. There have been a variety of studies looking at birth rates after different types of disasters, and that includes the 1918 influenza pandemic, hurricanes, earthquakes, famines, and typically there's a significant decline in birth rates 9 months later. So I don't think we can expect a baby boom in 9 months. There's a variety of different reasons, why there might be a decline in birth rates initially, from medical reasons, psychological, economic impact, and after the initial decline, typically once things stabilize, then there's usually a rebound in natural fertility rates. But I think again we can expect a decline in natural fertility and also obviously a suspension in fertility treatment. Here at Columbia University Fertility Center in New York City, we wanted to get a handle on what our patients were thinking. And so thanks to our fellows, Dr. Jenna Tarosi and Alex Robles, rapidly put together an 18-question survey that was sent to over 3,000 of our patients and partners we had seen over the last several months. We wanted a rapid response, so these results were collected within 48 hours, and we got over 500 responses. About half of these patients had had a cycle canceled or an upcoming cycle plan, not initiated due to the pandemic. Most of these were IVF or egg freezing or FET cycles. And 96% of these patients found having a cycle canceled to be upsetting, with 22% of them could be extremely upsetting, even the equivalent of what it would feel like to lose a child. So there's a significant proportion of patients that are very distressed about, not necessarily the guidance, but just the whole situation. The vast majority would have preferred to have had an option to discuss starting a cycle with their physician. Over 80% said they would have preferred that opportunity. And half of these patients, say that they probably would have started, and about a quarter are not sure. So I think, again, a lot of patients may have, not proceeded on their own, but they would have liked to have had more input. So there's been a lot of controversy around, the impact of a suspension or pause in fertility treatment. Again, while we know that some, like those facing gonadotactic chemotherapy, are at risk of a dramatic depletion, a rapid decline in their egg supply or sperm, and the guidance, recommended continuing care for them. Again, although they would be, at risk of, transmission of disease and also potentially more severe symptoms given their cancer diagnosis, but time we know is significant for those patients. The impact of delaying in the general infertility population is not as clear. So we know for sure that years matter. So especially as you get to the later reproductive years, late 30s, early 40s. So this is a figure taken from one of ASRM's documents on natural fertility. Many studies looking at natural fertility, different populations show a dramatic decline in natural fertility as you get into the late 30s, with very low chances in the early to mid 40s. That's been well characterized. And we also know when it comes to IVF treatment with the woman's own eggs, the success rate declines rapidly in the late 30s to early 40s. And so years certainly matter. So I don't think we can really reasonably expect these patients to wait for the pandemic to pass, which might be years, or for a vaccine to be developed, approved, and widely available, which is probably at least a year away. That's just not practical, or a significant proportion of patients will likely miss their opportunity to have children with their own eggs. We know success of donor eggs is maintained throughout this age. How about months? We don't know how many months this is going to be. We've had a guidance from the ASRM, and then an update in 2 weeks, another update in 2 weeks, and we're hopeful that that treatment will resume. And it's been mentioned 1 or 2 months, but really, again, we don't know how many months this is going to be. So I've heard in different webinars and discussions, the 4T trial, which was a randomized controlled trial, and that was referenced to suggest that a delay of maybe a couple or a few months may not be significant, even in an older population. So in this randomized controlled trial, which was really done now about 15 years ago, so IVF practice has changed in that time, but women aged 38 to 42 were randomized to 2 cycles of Clomid IUI. There were 3 arms. Our second arm was randomized to up to 2 cycles of injectable gonadotropins with timed IUI or immediate IVF. And those who did not conceive after 2 rounds of IUI were able to proceed to IVF. This was performed in a mandated state, primarily Massachusetts, which covers up to 6 cycles of IVF. And while the number of live births, the chance of a couple having a live birth, was similar regardless of which arm she was randomized to, patients got pregnant more quickly in the IVF group, and more than 80% of all the babies born were from IVF, suggesting this fast track to IVF may make sense in the older population. But again, applying this to our current pandemic, may not be realistic. This study, was a very well-controlled, randomized trial. We know that those may not always reflect real-world conditions where there's research nurses and follow-up. And we know that patient dropout is a real challenge. Even the best of times, a significant proportion of our patients would not engage in fertility treatment or would drop out if it was not successful. These patients might have been more motivated, those who signed up for this study, and they had the ability to keep going through multiple cycles. We can only imagine, but that patient dropout in the midst of or immediately after a pandemic will likely be higher, and it will be more challenging to go through up to 8 or 9 treatment cycles. Some patients may lose their insurance or their ability to afford fertility treatment financially, given the economic crisis that's going along with the public health crisis. And we also know that, in these mandated states, sometimes multiple IUI cycles are required before IVF will be approved. So again, these patients not only may be delayed, but then their IVF treatment may be further delayed if the IUI is not successful, or they might drop out before they even achieve it. And I've heard from some clinics that remained open to all kinds of treatment that they've seen a dramatic reduction in their volume, as much as 40%. And again, that's likely from fear, the economic situation, just following recommendations to stay home, or even leaving the area that was hardest hit by the pandemic. Again, I just want to emphasize that dropout is real and should not be underestimated. And as eloquently stated in this 2004 essay that was published in Fertility and Sterility by Dr. Penzias in Boston, called When and Why Does the Dream Die? A large percentage of patients discontinues infertility treatment despite a reasonable prognosis and benefits that cover the cost. Recognition of this problem and appropriate intervention may play a role in helping couples remain in treatment. So I think as we resume fertility care, we have to be very much in tune to the psychological impact that even when there was not a pandemic, patients dropped out of care, and it's likely to only get worse. So I'm going to shift gears now to talk about the New York experience here in the epicenter before I shift back to IVF treatment and how we go about resuming it. So being here in the epicenter, even without the ASRM guidance, it would have been very difficult to have remained open throughout. Unlike some other parts of the country and world where our staff, where your staff and your patients can drive to a clinic and wait in the car and be called in, most of our patients and employees travel through crowded subways, trains, buses. In the early part of the pandemic, PPE was limited, and there was concern about using PPE that might be needed urgently by hospitals, which might become overwhelmed. So, and with the number of cases, confirmed cases now as of yesterday, over 138,000, and likely many, many more than that, because a fraction of people are still getting tested. A lot of people are just calling with symptoms and being told to manage it at home unless their symptoms worsen. We've seen well over 10,000 deaths attributed to COVID-19 in the city. Pretty much all of our patients and employees, either some got sick themselves or know someone who is seriously sick or impacted by this. Finally, as you could see, this curve, is starting to flatten. These numbers are always delayed, so probably not dropping off this steeply, but we are seeing a reduction in the number of hospital admissions, number of patients in the ICU on ventilators, and the number of deaths are finally starting to come down. So the measures that have been taken to socially distance, to wear masks, seem to be working. In terms of New York City itself, interestingly, while Manhattan, where we are, which is one of the most concentrated areas for IVF probably in the world, we've actually seen the lowest rates of COVID-19 of the 5 boroughs. And there's different potential reasons for this. Manhattan residents may be able to work from home, different socioeconomic demographic potentially. They may not have to rely on public transportation as much as people from the outer boroughs coming into Manhattan. And also many people have left the city and gone to other states and other areas where they have more space and there's less cases. But shifting from within the New York, within the Manhattan experience to our own hospital system, Columbia Presbyterian, part of New York Presbyterian, our OBGYN department has really been leading the way on characterizing the impact of COVID-19 in pregnancy and at the time of delivery. So this situation evolved very rapidly. March 1st was the first confirmed COVID-19 case in New York City. Less than a week later, a state of emergency was declared. A week after that, the first deaths were reported in New York. Then on March 18th and 19th, there was a kind of sentinel event at Columbia Presbyterian, where, again, at that time, this whole situation was new and the status of PPE and testing was very fluid. And so there were two patients, both were asymptomatic. Everyone was being screened for fever, cough, and all the typical COVID-19 symptoms. And they were admitted for induction of labor, completely asymptomatic. This experience was written up by two of the Columbia MFM fellows, Dr. Noelle Breslin and Caitlin Baptiste, and their co-authors. So I would suggest looking at this if you want more detail, but basically both of these patients wound up becoming symptomatic during the course of their labor and delivery and postpartum, were subsequently tested and confirmed positive as far as SARS-CoV-2 on the PCR testing. Both wound up requiring ICU admission. And most importantly, because of the nature of obstetrical care with multiple providers, coming in and out, and anesthesia and examinations, it was estimated that maybe 15 to 20 providers had been exposed, with probably not the ideal being used at the time. So a very rapid response was taken after this, that decision was made to rapidly implement universal PCR testing for all women presenting to labor and delivery, and to really encourage or strongly recommend the use of adequate PPE, including N95s for all providers, on the labor and delivery unit, and surgical masks for patients. And then a very controversial decision to try to protect staff, and patients, was to exclude any visitors from the labor and delivery unit. This again also prompted a petition on change.org, which wound up having hundreds of thousands of signatures, and eventually our governor in New York issued an executive order to allow one support person, for the delivery period. This again got a lot of media attention, was very controversial, but I think given what was being seen, which I'll demonstrate in the next couple of slides, very high prevalence, and some with being asymptomatic, it was a reasonable temporary measure. So this is a larger series. Again, one of the Columbia MFM fellows, Dr. Desmond Sutton, compiled the initial experience from late March through early April, and this was published in a letter to the New England Journal of Medicine, that roughly 13% of all admissions to labor and delivery wound up being positive for the SARS-CoV-2 on the PCR nasopharyngeal swab. That's in testing 210 patients. The vast majority of those were asymptomatic. About 10% of those asymptomatic patients became symptomatic during the course of their labor and delivery. And then one of those who initially was negative wound up testing positive when she developed symptoms, underlying that there is a fault, like any test, there is false negatives. So the actual rate of positive patients may be even higher. And there's really no reason to think that pregnant women are more at risk of COVID-19. In fact, maybe you would think there'd be less risk, maybe they'd be taking more precautions. So this suggests that the prevalence of COVID-19 is fairly high in New York City at the height of this pandemic. So how has it been, shifting back to reproductive medicine, how has it been to practice reproductive medicine at the epicenter of a pandemic? So we took some, and many other practices took some rapid measures as suggested by ASRM, and also the rapidly evolving situation. we immediately switched to telemedicine, and I think it's been an amazing change. You can see here my schedule just a few days into it. All of the patients were converted to video visits, and it's worked out really well, although different than what we're used to. So we're used to seeing patients, doing ultrasound exam, getting blood work, and now this is going to have to be broken up into different parts. Just as the webinars are abundant, the Zoom or other platform used for meetings has become kind of overwhelming. We have daily meetings with our division, with hospital briefings, and our OBGYN department initiated a daily call where we get updates on policies and guidelines, PPE, etc. We decided to shift as much as possible our staff to work from home for those who did not have to be on site and directly provide patient care. And again, we were completing the treatments that were in progress and also managing early pregnancies. We divided into different teams to try to minimize the risk that a team, whether it's embryologist, andrologist, lab technologist, that they would all be exposed and not be able to work at the same time. And we were able, fortunately, there became more availability of PPE in New York, and we were able to provide PPE for those staff who do have to travel, that they could wear on their way into work and their way home from work and in the office. And eventually all patients are wearing masks, in the office. So I think it's helpful to maybe illustrate what it's like to practice with some clinical vignette. So this is a 28-year-old patient with severe malfactors. Husband works for the New York Police Department, underwent a single blastocyst transfer. Really, before this pandemic became, sort of overwhelming, we were still doing transfers. And then about 5 days after the transfer, they both tested positive for COVID-19. Normally, we would have brought her in for a pregnancy test, but to avoid exposure to our office, she was told to monitor at home. And when she was cleared by her primary doctor, fortunately, did not need to get hospitalized or anything serious. But after 7 days being symptom-free, she was brought in and we were able to confirm a viable intrauterine pregnancy, and so far everything is developing normally. So that's a good case. On the other hand, we had a patient who, with recurrent pregnancy loss, who was planning to do IVF, wound up having a home pregnancy test being positive at the same time as she developed classic symptoms of COVID-19. She was advised to stay home by her primary doctor. Normally, we would have confirmed pregnancy, we would have monitored the pregnancy with serial beta HCG, but instead we had to wait for her to become asymptomatic for at least a week, at which point she was more than 6 weeks from her last period, and on ultrasound, an ectopic pregnancy was visualized, and her HCG level was over 20,000. So again, practicing in a situation where the elective, quote unquote, elective surgeries are not being performed, operating rooms have been converted to ICU, even urgent surgeries, even like cancer surgeries are being delayed. We still felt it was safest for her to have laparoscopic treatment rather than risk methotrexate failure and needing more urgent surgery. But we had to wait 3 days for an operating room to be available. And fortunately, our excellent minimally invasive GYN surgery team was able to take care of her. She actually tested positive prior to surgery as part of their protocol, even though this was more than 2 weeks after her symptoms had resolved. An uncomplicated salpingectomy was performed with extensive PPE for everyone in the room because the laparoscopy is considered a high risk for exposure or aerosolization. So not surprisingly, with the ASRM guidance, we saw a dramatic decline, essentially standstill of our IVF volume. This is showing our egg retrieval volume by day, and then from the point of the guidance, now in April, basically just a few cases for fertility preservation for cancer. But the situation seems to have changed in New York over the last couple of weeks with flattening of the curve, with declining number of cases and deaths, and also Governor Cuomo clarifying a prior executive order stating clearly that sexual and reproductive health services, specifically mentioning infertility treatment and procedures, are considered essential services. So while there's a stay-at-home order for non-essential services up through May 15th, reproductive services are considered essential. In the meantime, we've been continuing to evaluate patients with infertility, and how do we go about doing that during a lockdown, even prior to when this type of evaluation was deemed essential. Fortunately or unfortunately, New York State has some very strict rules about diagnostic testing. Some of these options that I'm going to mention are not really available in New York, but I think are interesting things to think about as reproductive medicine evolves over the next few months. Some of these things are here to stay. So the idea of doing a telemedicine consult without any information about ovarian reserve is challenging. Again, normally we would get antral follicle count and AMH the same day, and now we're having to wait maybe weeks or months to get that information. So how do we triage who is most in need of urgent care? There is a validated at-home finger stick test by a company called Modern Fertility that is one option for patients, at least outside of New York, New Jersey, and Rhode Island, which has some rules against at-home testing. What about semen analysis? We want to be careful about having too many people in the office. The sperm collection rooms generally are small and not well ventilated. And again, how do we properly counsel a couple if we have no idea of semen analysis? We're putting those on hold. There is a at-home test by ReproSource, which is part of Quest, which I'll show. And genetic testing is also an important part of what we do, and knowing if a couple is at risk of a recessive condition and is it safe for them to continue trying naturally, or do they really need to consider PGTM? This can also be done remotely with saliva. At least some of the expanded carrier tests are able to extract DNA from saliva with a very low no result rate. At least from the saliva itself. Obviously, if patients don't label their sample correctly, they won't be able to run the test. Then a variety of other solutions like mobile phlebotomy have been investigated by some other genetics labs and companies. So the modern fertility test is basically a finger stick. A kit can be mailed to the patient. They can ship it back. It can test for AMH, estradiol, FSH, LH if timed appropriately in the menstrual cycle, prolactin, PSH, and this was published in the Green Journal showing very high concordance with venipuncture. The semen analysis also has been validated by CAP, and this can be shipped directly to patient. There's a kit for how they collect it. They ship it back by FedEx, and they get a report within a couple of days, a nice patient-friendly report, as well as a report in more detail for the provider. And we're also thinking about maybe new ways of collecting sperm. Even prior to the pandemic, this company called Protex has developed a device, a container specifically designed for sperm collection rather than the sterile cup we're all used to, urine and other things, which may not be optimal physiologically for the sperm. The temperature drops in that cup, even if it's warmed prior or even if it's kept warm. So this is designed to be a more physiological environment for the sperm. I think this would be more relevant for clinics that are moving towards home collection prior to IUI or IVF, probably more so than semen analysis. This is demonstrating some of the saliva kits and recommendations recommendations what you shouldn't do before collecting saliva, but there's some really nice videos online demonstrating the technique. Another interesting concept, which I haven't seen much use in practice, but I think it's something we should be thinking of, is home ultrasound monitoring. And there was a randomized trial published in Human Reproduction about 6 years ago that showed favorable outcomes. These women were trained in person, so that would have to be done potentially through telemedicine or perhaps one visit. But basically they were trained how to do a sweep with a vaginal probe and download to a USB. This could be done through the cloud, and the provider could watch these images. There's been a video at this website here, and the provider could measure the follicles and make decisions, perhaps even have very few or even no visits up until the egg retrieval. Obviously, that doesn't allow for estradiol monitoring, which we're used to, but something to consider in an urgent situation like we're experiencing. So at this point, I think, at least having been through the worst of, we think, this pandemic and hoping to continued improvement, we're starting to shift our focus towards resuming treatment. And there's a case to be made for it, and there's still many concerns. So we know we've shown that fertility treatment is time sensitive. We can't really keep pushing this off without compromising chances of some patients. And some patients may never be able to initiate care. Infertility is a disease, and this is what we do. We treat this disease. And once we pass this peak and we're comfortable that the PPE that's used in the clinic won't be needed by the hospital, and that if there are complications, although rare, like OHSS, like ectopic pregnancies, miscarriages, that it'll be safe for our patients to be managed. Then it's time to think about seriously resuming much needed fertility treatment care, because this virus will be with us for the foreseeable future. The concerns are uncertain what the impact on pregnancy is. Again, no major organizations are recommending against pregnancy, but we won't know the full effect for a long time, although we're continuing to learn more and more, especially for later term exposure. We can, however, postpone pregnancy while still preserving options with the freeze-all approach. So it may be reasonable to reinitiate care first for freeze-all in those patients at most risk for a delay, the older, diminished ovarian reserve patients. There's still concern about the safety of the staff. The clinic should be able to provide adequate PPE in the clinic and safety coming to and from the clinic, so that we can aim for as close to the COVID-free clinic as possible. And still, this concept of needing to flatten the curve, of not having people moving about when we're being told to shelter in place. And again, I'm going to go into some detail, but I think we can modify our protocols to minimize patient visits that they can perhaps combine with other essential things they need to do, and we can maintain physical distance in the clinic. So there's different documents out there that I suggest those more in the lab, look into from START and from CRB, but summarize, one, while treatments are suspended, it's critically important that we maintain inspection of our cryomaterials, monitor liquid nitrogen, that we make sure that we have an adequate supply of liquid nitrogen and other gases, that we keep our embryology staff safe for when they're needed for urgent cases and resumption of treatment, perhaps thinking about training other personnel for tasks like monitoring and filling tanks, or other cross-training if staff is limited, perhaps get extra liquid nitrogen if there's storage available and if possible, check backup generators, make sure there's enough inventory for when care is resumed in case there's any issues with our supply chain. And in preparation for this webinar, I had discussions with pharmaceutical companies and manufacturers of media and other products used in IVF, and they all assured me that they've taken many measures to also ensure the safety of their staff and the safety of the equipment and the media that we use, and they don't foresee any shortages, or supply issues, but we should be preparing for obviously the worst. To adjust your standing orders of media and to take some practical steps in the lab, like using PPE, minimizing, direct patient contact or contact with the lab staff with other parts of the clinic. I think they can be isolated in the lab, to avoid exposures like spills, cap tubes before discarding to biohazard, work in isolates or hoods as much as possible. So I think things are going to change, but can be done safely. So is it safe to resume treatment? Will we be able to wait until we have all these answers? I think so far, the limited data we have is reassuring. There's a in-press publication, from some researchers from China, actually here at Columbia and Utah, looking at semen from men in China who recovered from COVID-19. Interesting though, about a fifth of them had some scrotal pain. There was no detection of the virus in the semen, and there was minimal expression of some of the factors that are needed for cells to be infected by COVID-19 or by the SARS-CoV-2 virus. There's concern about our frozen material. Other viruses have really been shown to have a negligible risk of cross-contamination. And there's some references here, but the risk of embryo infection as part of being in liquid nitrogen appears to be extremely low, and that can be further reduced by washing with sterile liquid nitrogen. There's a paper describing that by Parmigiani, who's spoken in other webinars on this topic. And washing embryos after thawing can also dramatically reduce this, what's really a theoretical risk. But there are starting to come some papers, one from India, one from Dr. Zev Williams' lab here at Columbia, that there may be some expression of the ACE2, which is needed for infection. That doesn't necessarily mean that embryos can be infected or that the placenta will be infected. Still don't know, but this is an area of active research. And so I think for now, again, if measures are taken, I think ART can be resumed safely, but it's going to be different. So pre-COVID-19, we were used to busy waiting rooms, in-person consultations, sitting in a small room, for 45 minutes with a couple, return visits frequently, in-person meetings with nurses and coordinators, multiple visits, throughout the stimulation cycle, rapidly turning over exam rooms so that patients didn't have to wait, encouraging partners to come to visits, to be in their room for the embryo transfer, sperm production in small collection rooms, with another collection usually shortly after, signing consent forms in the office, using common pens. And this is going to be different. So post-COVID-19, for the foreseeable future, I think telemedicine is here to stay. We can leverage platforms to have virtual meetings, virtual medication teaching. We're already starting that here. This is an area of active discussion, but consider testing prior to start of stimulation. Again, we know that there's false negatives, but at least if someone is positive, there's a lower risk that they would become sick closer to egg retrieval and have to be canceled, and less exposure in the office. Temperature checks for patients and staff, spacing out the visits. I think we can do this, and make exceptions as needed, but possibly have 3 or 4 visits rather than 6 or 7 visits during a stimulation. Scheduling monitoring over a longer period to have fewer people in the waiting room, wiping down surfaces, spacing out visits in the exam room, having a longer interval between procedures like egg retrieval so that rooms can be cleaned, not having any other partners or visitors, collecting sperm off-site, potentially using novel collection containers, making more use of electronic teaching and consents, or cleaning or new pens if consents have to be signed. So in conclusion, the COVID-19 pandemic has had a major impact on New York City, and the practice of reproductive medicine here in New York and the US and worldwide. Telemedicine and physical distancing, this is the new normal. I don't think we're going back to the way things were, and we're just going to have to continue to get better at this new normal. Fertility clinics should adjust to this new reality and minimize, maybe not eliminate, but minimize risk to patients and staff. COVID-free clinics may not be completely possible, especially in high prevalence areas, but we can strive for that goal to minimize risk as much as possible. And fertility treatment is urgent. Dropout from care is real. And so as soon, I think, as we can perform treatment safely and responsibly, we should resume, the treatment that's needed. And so I thank you all for your patience. This is our team at Columbia University Fertility Center, but now looks more like this. And hopefully we have some time for questions. I'm sorry, that was a long presentation.
Thank you, Eric. This was a wonderful presentation. And yeah, we have many questions for you, but since there is no much time, let me just compress and chat immediately.
Okay.
There is the majority of them, they are just referring to the concept of the COVID-19 free clinics. And the first question is, did you test your patients prior to admission and again when they got discharged? And what test?
So again, we are just resuming treatment on patients who are most urgently affected by delays, older diminished ovarian reserve patients, and we have initiated just this week testing with the PCR nasopharyngeal swab at the start of treatment, and testing, screening for symptoms and doing temperature checks throughout the treatment. This is obviously a work in progress and will be reevaluated, but we made a decision to do that to, one, minimize, again, the risk of exposures in the clinic, and also the risk, again, that someone could be asymptomatic or pre-symptomatic and become symptomatic closer to retrieval and have to be canceled. So we decided not to retest closer to retrieval, but again, testing is still limited, even though we have the ability to do this for all of our treatment starts. Doing a second test, would be challenging, but I think that's a paradigm that some other clinics may choose to adopt, and I think we'll have to continue to evaluate and have presentations and see, if that's useful, if that picks up, and avoids some risk. But our decision has been to test at this prior to start of cycle, before they come into the clinic for treatment.
Okay, thank you. What about donor testing? Is the same?
Donor testing, again, I mean, at this point, we have not resumed, donor egg treatment because we know that's less time sensitive, and we also, don't want to put donors at risk unnecessarily until hopefully, things are lifted and travel is more allowed in this region. But I think that testing and screening will be similar. It's not yet mandated by the FDA, but basically anyone who's going to be coming through for treatment at our center will have a negative PCR test prior, and then screening and temperature checks at every visit. And we'll still all be functioning, assuming that they could be positive, that there could be a false negative. So everyone will be wearing PPE, and in the OR at the time of retrieval, gowns and goggles or face shield.
Okay, what about, do you have any special consent for patients at this time in the pandemic?
Special concern, I mean, again, I think we're all concerned and taking precautions, about getting sick. I mean, fortunately, and again, I'm not an epidemiologist, but it seems like, although we have heard stories of younger patients. Yeah.
Sorry, I mean consent. Maybe I did not.
Consent.
You are handling just a special consent form at this time.
So again, I mean, this has been an area of active discussion, and there are consent forms going around discussing, the risks, and we made a decision that we're documenting that we're counseling on all of these components that would be within the consent. So I think either a signed consent, again, whether that's electronically, hopefully given the situation, or a discussion with the doctor that's documented, should outline the things that are different, the testing, the temperature checks, and that the cycle could be canceled with short notice. So patients are going into it with that understanding, and all of our patients have understood that and have been willing to proceed. And we're trying to take measures that if they happen to get canceled, we haven't had to do that yet, that there wouldn't be any financial implications for them. Once they're recovered, the following month, we would hopefully be able to resume treatment. And I know the pharmaceutical companies are working on programs to reimburse patients or give them samples if they get canceled during the cycle. So we don't want people to hide symptoms, because they're worried about the financial implications. If someone gets canceled, we will resume treatment as safely as possible. But there definitely has to be counseling, documented, and/or consent.
Well, thank you, Eric. We are just out of time. I have very interesting questions, but for the sake of time and for the time of our assistant, I think that we have to close here. You got 950 colleagues in your presentation. I want to thank to all of them for the interest, and I want to thank you, of course, for your work and your wonderful presentation.
Well, thank you. Sorry for not leaving more time for questions. There's a lot of stuff I didn't include too. It's a very, very hot topic. But thank you, Dr. Simone, and I look forward to the rest of the series.
Well, thank you very much. Thank to you all, and we wait for you next week at this time.
Okay, thank you.
Thank you all. Bye-bye.